when it comes to painful sex, something that I often talk about with my patients is this thought of before care and after care.
Today, I'm speaking with Sabrina Sarro, a pelvic pain psychotherapist who works predominantly with communities of color and round race, gender identity, and chronic illness with an emphasis on urogenital conditions and painful sex. Thank you so much for joining me today to answer some of the questions from our community.
Well, thank you so much for having me. I am beyond honored and humbled to share this space with you.
Amazing. Well, we have a lot to cover, so shall we just jump straight into the questions?
Let's jump right in.
Let's
right to it.
So I thought it might help to provide some context for this discussion if you can provide an overview of psychotherapy and the training involved.
Yes. So psychotherapy typically is an umbrella term that talks about, or that spans rather, an individual who typically has completed at least 2 years of postgraduate study from an accredited university. So this could be any university across the states, and I'm speaking primarily through the lens of the United States. 2 years in depth of over typically 2,000 to 3,000 clinical hours at 2 internships over those 2 years, being supervised in multiple modalities ranging from CBT to DBT to psychodynamic therapy, and really having hands-on active experience in the field of choice. Usually in the first year of any psychotherapy accredited program, the individual gets to sort of experience maybe a niche or a community that they want to grow in, or that they want to learn more about, or that they want to further cultivate a skill set in. And then usually by the time the second year occurs, the individual might have an opportunity to get more clear on the path that they might want to pursue. And so that second year is really rooted in applying for an internship of choice that really speaks to the individual. So it's really a robust 2 years filled with coursework, internship, clinical supervision, group supervision typically, and then after studying for your boards, which essentially means getting licensed in the state that the individual might reside in, the first major license typically for psychotherapists or licensed mental health counselors or behavioral therapists of any kind.
Okay, that's really good. Provide some good context. In the space that you work with pain during sex and chronic illness, I know there must be a lot of overlap with sex therapy or sex therapists. Maybe you can also give us some insight on what the difference is and whether a sex therapist is usually a trained psychotherapist.
So absolutely, a sex therapist must be a trained psychotherapist. So usually that's the prerequisite before one can typically begin to usher themselves into these more genre-specific realms. But yes, I'd say the major difference is that a sex therapist must be accredited through, in America, an organization called AASECT, which is just sort of an acronym that stands for the American Association of Sexuality Educators, Counselors, and Therapists. So typically sex therapists will undergo a very specific criteria and will undergo a very specific curriculum where they will be supervised by an expert who will be talking about everything ranging from BDSM, possibly the kink community, painful sex, typically, from what I've seen, vaginismus, endometriosis tend to be covered, but not so much recurrent UTI, IC, vulvodynia, vulvar vestibulitis, right? But typically, a sex therapist will have more in-depth training and might be more suited to help somebody more long-term, and might be more equipped to help somebody with trauma-informed or trauma-based sex-related presentations or conditions as well. Yeah, so the main difference is that they are accredited. They are typically accredited through AASECT. However, some psychotherapists who might not be accredited through AASECT still can practice sex therapy, still can have training like myself. I am not accredited with AASECT, but I don't claim to be. But yeah, those folks just have a more they've gone through that path, and they've gone accredited that way, and they have a very specific curriculum. So folks are looking folks are looking for that blue stamp, then look through AASECT and find a credentialed sex therapist that way.
Yeah, that's a good tip. Why do you think it is that those conditions like IC and chronic UTI are not covered by those types of specialists?
Yeah, and I mean, I don't want to speak for all sex therapists. There very well could be sex therapists out there that cover those, but just in my personal experience, my own journey beginning to get credentialed through AASECT, or my own journey doing maybe more formal programming or training around sex therapy, I typically have not seen anything touch the surface around IC, UTI, recurrent UTI, chronic UTI, embedded. I've seen nothing. And why do I think that is? I think that crosstalk, urogenital, all these urogenital conditions to me seem to be the most under-discussed, underfunded, under-recognized fields of urogynecology, of urology. And I think that, coupled with the fact that we are not talking about these conditions, or we are talking about these conditions at a disproportionately lower rate than we are maybe vaginismus, endometriosis, or erectile dysfunction, painful right? Like I think we're talking about some, but then the others that I named are still grasping and reaching for air, and I think that that speaks to how little so much of us know and have put the effort into knowing.
We definitely see that overlap into research into these conditions too. The funding just isn't there and the research isn't done. And that makes it really hard for practitioners of any specialty to have the information they need.
Yep. So I'd say this is like a scarcity model, where, so many of us, including myself, both personally and as a practitioner, are grasping at straws sometimes. Scouring journals, scouring med journals, asking the professionals in the field. But I think other than that, what's really been abundantly clear to me is how understudied and how underdevoted these conditions are, and how they affect so many people.
Far more people than statistics would show, I think.
Far more people, and the disparity of that, and the violence of that disparity, quite frankly.
So let's talk a bit about painful sex. For someone that is experiencing painful sex, when does it make sense to seek the help of a psychotherapist or a sex therapist?
I would say immediately. I don't think that there's any lag time to not see a psychotherapist or a sex therapist or a psychotherapist that has a big bend in the world of sex. I think anytime somebody is in pain, physically, emotionally, psychospiritually, that is a good invitation to seek support and to seek entering into a relationship with a practitioner that aligns with what that person might be looking for, and to really begin all that encompasses. So for me, I typically don't put any time rubric on that. I think any time can be a good time to seek the support of a psychotherapist or a sex therapist. And I invite that to all of my clients and all of my patients who are even at the beginning of painful sex. Just having somebody in your corner, having somebody that's trained, having somebody that can hold you at whatever stage you might be in regards to painful sex, can be paramount to nervous system regulation, holding, affirmation, support techniques. And so I think at the slightest nag of painful sex, I would recommend seeing a psychotherapist, or at least having one on hand, even if that's not the main thing you might be coming for. I think always an open door for psychotherapy and something to be received. Do
you think that kind of therapy can kind of complement treatment, other medical treatment that you might be working on at the time?
Oh yeah. And I would even dare to say that instead of complement, I think it's imperative actually that it goes side by side. Like I think that the sheer trauma of having to navigate a medical system in which your urogenital symptoms or experiences or conditions are, number one, so widely underfunded and underrecognized, and then coupled with the pain or agony or ache of having to live in a body that people routinely are not understanding or are not taking the time to understand. Oh, I think like seeing a psychotherapist needs to be, if not one of the major things, one of the major first things in the toolkit. Yeah, I would really stand by that. As as antibiotics can be for recurrent UTIs, I think psychotherapy is for all of these things as a major, is one of the emotional antibiotics I'd put in the group, so to speak.
I think a lot of people can use that support. You mentioned having someone to hold you through that experience, that the decisions that you need to make, sometimes it really does become overwhelming.
Yes. And having somebody who has not only expertise in these conditions, who isn't just like a third party listening and learning through the patient, but is actually coming equipped with their own separate knowledge, and who can really come to the space well boned and well furnished with ways to advocate, ways to help locate pain, ways to help talk about these things with loved ones. I think it's life-saving.
You just touched on a few of the questions that are coming up. The first one is about painful sex and how, whether you might have suggestions for things that can make people feel safer to engage in any kind of sexual activity.
Yes, so the first thing that comes to my mind is that you always deserve to have the type of sex that you want to be having. In any capacity, in any space, in any iteration, it is your divine birthright to be having the sex that you want to be having. And so when it comes to painful sex, something that I often talk about with my patients is this thought of before care and after care. And so before care can just look like any sex rituals or sex routines that really make the individual who's experiencing the pain feel more at ease, So this can range from, hey, I really, I need to have like a diaphragmatic breathing session or a mindfulness foreplay before we usher into any other sort of physical modality during sex, right? Like this could be, having a hand washing practice, having like, a supplement, any regimen that the person might not want to open up about or feel scared to open up about or feel anxious to open up about. I think it's so important to like have a very clearly defined definition of what you want your before care to be, how you want to really stage the sex you want to be having to set you up for success, to set you up for maximum pleasure. And so, and to piggyback off of that, I think aftercare is just as important as before care. And so like before care can also encompass speaking to the person that you might have sex with beforehand and like letting that person know, hey, these are some things that I deal with. These are some things that are really important and meaningful to me whenever I possibly have sex with someone. How do you feel about what I'm saying? This is what I typically do to make myself feel safe. I would really love to have a conversation with you beforehand to talk about ways we can incorporate and center that so that maximum pleasure can be accessible to me and to you. That can be a conversation. And then I think aftercare is just as important, whether it's water time and peeing after sex, whether it's, whether it's
everyone has a thing.
Everybody has a thing, whether it's your anything, your prophylactic, who knows, like whatever it might be, whether it's talking about different barriers, different types of contraception and what that might do, whether it's talking about lubes that help the person and that don't give the person anxiety. Like, I think being really upfront, being really bold in what it is that you want and what you need in regards to before care and after care, I think what I've seen and having a therapist coach or support patients through that can be life-changing, can be revolutionizing for sex.
And that conversation is so important, but we hear from a lot of people, even in long-term relationships where they feel they can trust their partner, to understand, they still can't start the conversation. Do you have any ideas on how to make that easier for people?
Yeah, like I think for people who find immense anxiety in beginning that convo, starting off small can, I think, often be a
Mhm.
good way to open the door. So for some of my patients who say to me, "Oh, Sabrina, like I don't feel comfortable yet bringing that up to my partner, or I feel a sense of guilt or shame." Sometimes we'll think of, or we'll play or think of like creative ideas of how we can broach that with our partner.
Mhm.
So sometimes I might invite the partner into a session. Sometimes I might encourage the client to maybe write it down on some index cards, or like whatever way is intrinsic to that partner's communication style, and
Mhm.
whatever method through which the individual finds safety in typically speaking to their partner. Sometimes we'll use that as the bones for forming a body that feels more comfortable in, hey, actually, like, this thing doesn't actually work for me so much so during sex, or this thing I noticed actually makes me flare, or actually causes this symptom in me, and I was wondering if we could make this swap,
Mhm.
or so, like, finding creative ways to dilute some of that anxiety or to abate some of that, while also investigating and exploring small ways to play and flirt with, how do we deliver a message to someone we love, and
Mhm.
how do we do that in a way that makes us feel comfortable, and like how can we play with another genre of life that we might feel comfortable with talking to our partner, how can we transfer those skills, something called
Yeah.
transferable skills in psychotherapy, how
Mhm.
can we transfer that and plant small seeds to make the person feel more comfortable, and to also make the nervous system feel more comfortable as well in
Mhm.
delivering that. So those are some of the techniques that sometimes I will play with my patients and explore, like, how can we deliver this in a way that makes you feel good about the delivery.
Yeah, feeling good is kind of brings me to the next question. A few people mentioned that
Yeah.
when you do have pain during sex, or sex with a specific partner triggers UTI, it can be difficult not to somehow feel like that partner is contributing to your issue, and they don't understand your physical pain because they're not experiencing it. And so people have mentioned feelings of resentment and anger towards a partner, and not knowing whether it's healthy to bring that up, given they know that it is not something
There.
that is real necessarily, but it's there. And
It's
how
there.
would you recommend that someone deals with that?
So I think the first thing that I'm inclined to say is that I think in any partnership, whether it's a long-term relationship, someone you might have just met, someone you've been having sex with for a specific amount of time, I really, really encourage my patients to talk about that resentment, and to
Mhm.
talk about that shame, or that anger, or that upset. Um, I think those feelings are 100% valid. I think it's absolutely reasonable and good and okay to come away feeling like, yeah, I'm actually pretty resentful, or like, you don't have any understanding of what this body is going through, or what
Mhm.
this body has to hold after sex, or any iteration or constellation of thought that comes up. I think it can be really useful to actually invite your partner into that. And I know, and I acknowledge, and I respect that people might shelve it, or want to talk about it somewhere else, or might want to sublimate it into some other activity, which is totally fine too. But I
Mhm.
actually think that inviting your partner into those feelings can be a huge growth point for both people,
Mhm.
not only for the person, um, not only for the partner or for the person that the individual might be interacting with or having intimacy with, but I think something that I've noticed is that us chronic pain experiencers, most of us, don't talk about these things directly, don't name these things directly,
Mhm.
feel a sense of general shame, anger, upset, anxiety about talking really frankly and
Mhm.
boldly about what it is that's happening, and like what we're contending with. And so I think saying, hey, like, I just want to let you know that I'm becoming present to some feelings in my body around anger and resentment around you. And I'd love to invite you into a conversation where maybe we can just let those thoughts have breath. And
Mhm.
it can be something as direct as that, and like just holding the fact that like those feelings are coming up, and like maybe that can offer an invitation for the other person to be like, I hear you. What would be helpful for you in this moment? Do you want to walk me through the anger or resentment? Do you want to walk me through the parts of your pain that I know I won't ever be able to understand, but I want to learn as much as I can. I want to go as close to the center as I can, and I think this could also be a good exercise and a good way for the person experiencing the painful sex or the pain in general to just kind of get comfortable nervous system wise and emotionally, naming directly like this might be part of aftercare. Like part of aftercare might be toggling the tightrope of frustration and desire, or wanting to have great sex and then having it be sort of having it be paired or twinned with sadness or despair or upset or resentment. And so I think like naming feelings can be such a huge power moment of just giving what's happening in your body a chance to breathe.
I think the sadness, or the pairing it with grief and sadness, is a strong theme. And another is that a lot of people they feel guilty about not being able to have the sex that their sexual partner wants them to. And that is also something that's difficult to work through, and kind of ties into the theme of grief and loss with chronic illness and how you can process that grief.
Yes. And that's why I think seeing a therapist of any kind can be just a radically beautiful way of not only having a professional in your corner, but having a heart worker in your corner. Having somebody who's giving you unadulterated time to just hold and love on you and support you in processing the complexity of what it means to be in a body that isn't working the way we might want it to work necessarily, or that's posing challenges that not everybody has to contend with, And so I think that grief is so real. It is there. It is absolutely present. And I think like honoring that is a huge part. And I think not even rushing to like solutionify it or rectify it or dilute it even, but just sitting with it first and foremost and being like, no, I'm in this state of grief, and it is a real state of grief that I am in. No matter what happens, I am in this state of grief, and just holding that, being present to that before like we can really go into that narrative and like see where we can turn or hold or play. I think just really being present to like, no, sometimes it's really shitty and I'm grieving and I'm hurting and I just want to be in my hurting, and maybe I want to just be held in that and not told, well, it could be worse, or well, like all of these platitudes that we are given or heard around, well, at least it's not this, or let's try to change the narrative. And like, I'm not discounting that, but I think a huge part of the benefit of seeing a therapist, the benefit of going to couples counseling with your partner or partners, or going to groups that talk about this, support groups, is just getting to talk about the real pain of it, the loss, and the death of a body sometimes. That often is a theme I talk about with my clients. Yeah,
I think that comes up quite a bit in our community, and I do agree that it's important to acknowledge that, even though sometimes it feels like acknowledging that makes it harder because you don't have certainty of how long the journey will last or what comes next. And you try to keep things together, I guess, because you need to make decisions on a daily basis.
Right. You need to live. You need to still live. Yep. Yep.
And for people that actually have overcome the physical side, because we do hear from people that overcome their chronic infection, but they find it very difficult to separate anxiety from sex, understandably. And are there tips that you can offer, or exercises that people can do in order to move through that?
Yes. So for clients of mine who have either reached remission or are very close to remission and find that like they're actually feeling quite good, but that the smog state of trauma continues to sort of smear itself everywhere and creep in slowly into pleasure-inducing activities. Sometimes I'll recommend a wonderful CBT, which stands for cognitive behavioral therapy exercise, which is called like a thought diary. And a thought diary typically has specific columns, one that typically starts with the situation, the evidence for the situation, the likelihood that this is going to happen, how we can like reframe the narrative and arrive, like what is the arrival point that we want to move to in regards to the feelings that we really want to have. So sometimes I'll coach my clients through, okay, yes, we have a history of chronic infection. We've had a history of that. But the evidence over the last 6 months speaks to the fact that we've had sex before and we didn't get reinfected, or we didn't have a flare. So I think like speaking to that, like really reaffirming and re-reminding that we've like the evidence and history over X amount of time actually shows that we've done really well. And like, can we for a moment stay in that wellness? And if we find that thoughts of anxiety are creeping in when we're about to have sex, or when we're about to go in the pool, or when we're about to drink alcohol, whatever it might be, like I really encourage mindfulness in my clients. And I really encourage like, let's focus on the beautiful data that we've accrued over the last X amount of months or weeks. And let's talk about all of the proactive things you're going to continue to do. And let's try to actually divorce ourselves from the haze of illness and try to mindfully enjoy what we can enjoy in the moment. And I know that's a lot easier said than done, but a technique that I try to really hone in on is just kind of how can we reframe and use emotional data and physical data to our advantage. Sometimes this might include index cards, whiteboards, sending a text to yourself every day on a specific app, or an alarm, or anything like a voice, like creative. I'm really creative. So just creative ways to be like, hey, I had sex 10 times so far and I didn't flare once and I had a great time. So I'm having some anxiety for this 11th time right now, but I'm going to remember that the trajectory so far has actually shown me that I can have sex and not flare. So I'm going to really center myself in that narrative before I go in, even acknowledging that anxiety is present, and do my best to really focus on the locus of pleasure that I can really, just that I can really collapse into, and allow myself to just bend into. So those are like some of the broad strokes of techniques that I might offer. Like hyping yourself up before you have sex, a sex date, like, and I know like sometimes sex is spontaneous and all of that, but sometimes like I will do a lot of work with my patients to really get them in the mindset that no, like we're gonna have great sex on Saturday. Like talk to me about the scene, talk to me about what you're gonna wear, talk to me about, set the narrative up for me about what you want your sex to look like on X day. And like I think really like honoring the anxiety, but amplifying the excitement, amplifying what has worked, amplifying the fact that, remission is remission and you are there. And let's not let anything thieve you of that, because that's real and you got there. Or you're just there on the border, or you're, like, let's not let that thieve you of any more time than chronic illness already steals from us.
Yeah, I mean, that's a good point. It's so hard to let that go, but it really needs to happen at some point if you can.
Yep, it's a thief, and it steals our time and our personhood. So, I always encourage, let's keep anxiety there because I know it's there, but let's amplify the other stuff. Yeah, like what can we heighten? Yeah. And how can we make anxiety stay small? It's often a way that I'll ask that to my patients.
Yeah, I like that idea. I want to revisit the different types of pain. You mentioned early on in the interview about, like, for instance, vulval versus vaginal versus bladder pain, and how you can tell the difference between that. But are there tools that can actually help you pinpoint where it's coming from?
Yes. So I often like to do an exercise called a body map with my patients, where this can also serve as a dual purpose, not only for locating where physical pain might be coming from or where referred pain might be originating from, but also just to also pinpoint and name and give language to feelings that are living in each of these parts of the body. But yes, I have a lot of like, just random things around me, like, where's my vagina puppet or my vulva puppet? I just have like random fun, models that I typically like to use with my patients. But typically, like, I will talk about what is the vulva, what are the different parts, what typically is defined as bladder pain, how do we differentiate that from more broadly localized pelvic pain. So I will go into like the definitions. I will go into really, really asking my patients to close their eyes and really move me through where the pain is happening. And sometimes people will say right under the belly button. Sometimes people will say right under the mons pubis. Sometimes people will say not the vulva, but just the urethra. Sometimes people will say all of the above. Sometimes, and I'll really ask very specifically, like, what does pain mean for you? When you're having pain in any way, pain during sex, is it a burning? Is it deep inside? Does it feel like a lightning bolt? Does it feel like it's scraping something? Does it feel like a hard clamp or cramp? Like, sometimes I will use direct language like that to really map out how we can sort of precise as best as we can where the pain might be coming from. And, I'll often share what I've learned, like suprapubic pain, vulvar pain, right? Like pain upon the bladder filling, or whatever it might be. Like I will typically say, like, this might be a way to consider the bladder as a possible ingredient in this cocktail that we're trying to understand, or okay, burning upon insertion, interesting, that might be the vestibule, that might be, that is often the vestibule, the vulva, the vulvar tissue. Do you have pain during a speculum being inserted in you? Do you have pain during a pap smear? Do you have pain here, there, and I think like same thing for people who might not be in AFAB bodies, AFAB meaning assigned female at birth. I'll often ask people, like, is there scrotum pain? Is there penile pain, right? Like, is there pain upon ejaculation? So I'll often, we will body map to try to get as precise as possible, and to use that body map when seeing physicians, using that body map, using those diaries, using the tracker to really also bring that as emotional data and physical data points to equip ourselves in letting doctors know, no, this is what it is. Here's what I collected. Here's what I need you to help me diagnose.
Yeah, I was going to ask if there's certain points or certain types of pain where you might then suggest seeing a medical doctor for that.
Oh yeah. I always try to pair my work with my patients with a medical doctor. And so part of like what my style of care includes is supporting patients with finding in-network doctors that not only represent their value systems and look like them, because I am working with mostly TGNC, which means trans and gender nonconforming, Black, BIPOC, Black and Indigenous people of color, because I am working pretty much, predominantly with those communities, right? Like, how can we find somebody that takes our insurance? How can we find somebody that looks like us? How can we find somebody that we don't have to travel 3 hours to go see out of state when that's not accessible for us? And then if we can't, how do we crowdsource? How do we crowdfund? How do we find different ways, grants, innovative ways to possibly see someone we might really want to see who's out of network or whose price range we can't necessarily afford, or who...
I imagine that takes a lot of work given how few specialists there are anyway that can deal with these issues.
Exactly. So like I have a whole database in New York of just, all right, let's try this practice. All right, let's get on the phone together and ask, what's the NPI number? Let's go in, let's call your insurance, let's cross reference, let's make sure there are no surprise anything
Yeah.
when we're already navigating surprise in our body minute by minute. And so that's something that I'm really big on. And so, 9 times out of 10, pretty much all of the people that are seeing me, I am well connected to their medical team. Yeah. So like I might speak to their doctors. I might speak to their whoever's. I might speak to their their pelvic floor physical therapists. So we are all, it is a real robust care team. And yeah, seriously. And I'm just one of the limbs in that. And I think any pain of any kind, yes, a medical provider should always be looped in and included, but the right medical provider, not one that's going to gaslight you, tell you that it's all in, which happens, tell you it's all in your head, negate the scientific, whatever, just negate UTIs in general, negate the connection, negate all of the connections that we know to be true. That's half the battle too. Like, Sabrina, I really need help finding a doctor, because every time I go see one, I leave more traumatized.
Yeah, I can sympathize with that. And we hear a lot of that from our community too.
Right.
At some point, a lot of people just stop going to doctors because of this problem.
They stop going. And, I get it. Like you go, you have a limited time with the doctor, maybe 15 to 20 minutes at most.
Yeah.
And it is a rat race to get your questions answered, to feel like you're being really heard, to bring up points, to actually pick their brain about what it is that they've been trained on, and I think like this also speaks to this, what I think is this elusive culture of medical school, where like we're seeing these professionals who get paid so much money to treat and help and diagnose us. And in reality, we get such little time to actually learn from them. It's like you've just done 10 years doing a fellowship, a residency, 4 years of medical school. And I hear people in the community all the time saying, doctors don't answer my questions. Doctors get annoyed when I ask too many questions. Doctors say, well, save your questions and come up for a follow-up, where I then have to pay $75 just to ask you questions, when you could easily be answering my questions through a portal or through like I see this as well. And like, it's not to say that doctors aren't busy, which I know they are, and I respect that, but I just think it's really interesting that like we know so little, we don't get to actually bear or receive the fruits of what these highly elite lauded fields have gone, have done training for. So I think I also talk about that with my patients, like get your questions ready, do not leave until your questions.
Yeah, that's a huge thing. We often tell people to prepare as well, because otherwise you're going to miss your opportunity, and it is a very small opportunity most of the time.
Right, it's a small window, and stay there until your questions are answered. You are entitled to have your answers questioned.
Yeah, absolutely. Agreed.
Yeah.
Well, we talked about differentiating physical pain and where it might come from, but there was also a few questions around psychosomatic pain, or pain that might be triggered by mental factors. And are there ways that you can kind of tell if something is triggered by mental factors or if it's physical, or both?
Yeah. I'd say like something that I often try to support my clients through is when we hear psychosomatic or what might not be actually happening that's connected to the physical realm, like let's talk about like what leads us up to that. What's the narrative that typically, or what's the narrative arc that's getting built that's leading to those psychosomatic or to what we are questioning as psychosomatic feelings, And so in my work with my patients, something that I try to do is, at a certain point, I think it becomes less useful to distinguish between psychosomatic and what's real, because at the end of the day, the person is still suffering and experiencing symptoms. And so a good way to differentiate sometimes is to really focus on, when are you not experiencing those symptoms, right? Like, and I think like psychosomatic to me can be, sometimes when people are anxious, or when people are about to go on a date, or any high stakes thing that they might determine to be anxiety inducing, sometimes we can have very normal, real nervous system reactions, right? Like you might notice you have more frequency possibly, or you might notice diarrhea or intestinal stuff, or you might notice you're hot or you're sweating more, and like, I think it's really important to practice like bodily intuition when it comes to separating the two. And like a psychotherapist can often like guide the person into what that really means. Like, what do we know about our body? What have we been taught about our body that we actually don't align with? And what do we want to reteach ourselves about our body that we do align with? And so I think like, to make a long story less long, sometimes I will guide my clients through, okay, like, well, let's go over the history. Like, we know that getting on trains is a source of anxiety for you in New York City, especially in light of all of the shootings that have recently taken place in New York City. When you feel like you're about to leave the house, you notice that there's an increased urge to pee, and that you notice that you're peeing more frequently whenever you leave the house to go to the train. But when you're driving to your parents' house, you notice that that's not happening as much, or you notice that it's right. Like, can we start to really localize and pinpoint where the small dissections might be between what's actually a trauma-induced response or a nervous system response or an anxiety response versus, no, now it's actually a blend of, I don't know what's happening and I'm still urinating frequently regardless of, or I've trialed it, or I've seen that plane, train, car, regardless, I'm still having these symptoms. And so I think like the answer to that is not a short one, nor is it an easy one. But I think the most important thing to remember about that question is the person is still in pain regardless. And obviously, yes, we can tease through what's psychosomatic and what's really happening, but I always try to have my focal point be, regardless of what's not happening in reality, from where or from which place, this person is still in pain. They're still not experiencing levity in their day-to-day functions. And so let's scale back and tease out what might be happening. And so, going through the person's history, going through trauma history, going through what we call a biopsychosocial, which I'm sure you're familiar with, but just like getting more familiarized with like intuitively, what does this person think is happening? Why do they think it's psychosomatic? Why are they worried it could be? Is there a trigger point there?
Sometimes I think it's because a clinician has told them that it might be. And at some point they've heard that the test is negative so many times that they have to start thinking about other options.
Exactly. To live. You bring up an amazing point, right? Like where did you arrive to even the language of psychosomatic? Yeah, like that's a question I ask my people all the time, because intuitively the body's telling us something.
Yeah.
But who told us that it might not be real, right? And that's not to say that there aren't situations where that is absolutely valid and does happen, but more often than not, what I see is, no, there's real pain. There's real pain, and it's the chronic development of this bruising the nervous system over and over again that then leads to the person being like, well, I don't know anymore. I'm actually fully, I'm seized and kidnapped by the haze of the unknown, because no one's treating me, because this urine test came back negative, but the other one came back with Lucas, it's just like, but I don't know, but we did all these, I think then that speaks to really how deeply true it is that people do not know what they're doing and like don't know enough about what they're claiming to treat. Right? Like
I do worry about the portion of our community who has reached that point where they haven't been helped by medical care, and now they're just left thinking it might be all in their head, when I agree with you, it probably most often isn't.
Yeah, most likely. What I've seen after doing this for the last 7 years is that it's not. You wake up one day and you know very clearly something's wrong. You know very clearly, and because you're in an AFAB body, possibly a Black body, a trans body, a fat body, a darker skin body, for whatever constellation of reasons, it will be harder for you to get the answer that you need. And then it becomes, how do we just stay alive as we try to advocate and fight for our lives?